All right, well, welcome. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from what to why. Because when we understand why we do what we do, it changes everything about the how in the patient care decisions that we make every day. This topic review is focused on evidence-based medicine. We'll be covering the final 2 steps of the process of implementing evidence-based medicine in a patient care scenario. Remember, it's been singular as it relates to a clinical case or patient care situation. If you have not watched steps 1 through 3 or determine what is evidence-based medicine, don't assume that you actually know. I know it seems intuitive, seems assumed, straightforward, but actually there's a lot of EBM terminology that isn't clear. We all need to be on the same page. Those other steps serve as the foundation for these last 2. These last 2 seem pretty straightforward, but we continue to build on them, and I would encourage you to go back and watch those if you have not seen them yet, so that you can establish that good integrated solid foundation. All right, as a reminder, evidence-based medicine is the compilation. Again, the Venn diagram demonstrates this imagery the most when the best available evidence combined with our clinical expertise, patient-specific factors all come together. That is EBM. Again, we have been focusing our time in this series on how to find and assess and apply the best available evidence. And that's where a lot of people spend most of their time. But we, again, cannot assume or disregard the input of the clinical expertise and or its limitations, depending on where you're at in practice and what you do, but also the patient-specific factors and or preferences so that you apply the right treatment intervention and decision for that patient, not necessarily for all your patients. So here we are in the last 2, and I combine them because there is some overlap and merging, if you will, between the 2. And a lot of times people forget the bottom one because it's buried at the bottom, but it's kind of that loop back to the beginning, okay? And some people even consider calling that 5th step not just assess, but adapt. That means you are learning more about the literature, how to apply it, and then because you've assessed your own clinical decision-making and your own practice, you are now adapting your clinical practice to align with the literature where hopefully your outcomes are improving and in line with the best available evidence and practices. So step 4, apply, okay? Now, each decision that we make in practice has to have some degree of element of contemplation and also a judgment. In most cases that you see, patient scenarios, that patient doesn't necessarily always perfectly fit the evidence that you may have found. Remember, evidence, especially the primary literature, the actual research, if it's a clinical trial or a study, then there was an inclusion-exclusion criteria. If you're a purist being, you're going to practice evidence as it only occurred, well, most of your patients probably don't align with the inclusion-exclusion criteria, so you're going to find yourself with very little evidence most cases. So at some point we have to say, okay, well, the patient generally fits in this bucket, but realize that there is some element of that. And that's what comes out during the appraisal process, where we are systematically reviewing the paper and comparing the paper's PICO to our PICO for that patient care situation, okay? Now, when we apply clinical trial data, we need to consider some of the following. Right? The patient population that was included. That's straightforward. These are the 4 main elements, if you will, predominantly of the PICO or the clinical question. But the patient population, inclusion-exclusion criteria, the timing of that measured outcome influenced by the setting, right? And then your own bias Do you have bias? Of course you do. You may not want to accept that. You may not want to acknowledge it, but the reality is we all do. Right? And it's important that you recognize your bias as you're assessing the information so that you can be fair and balanced. Because sometimes the best thing for one patient may not be aligned with your bias, okay? So we need to recognize that fault in ourselves. And so when you combine the best available evidence with the clinical expertise and you factor in those patient-specific values and preferences, their access to care, the socioeconomic issues, their insurance, all these things, it becomes important to generate the best outcome from the patient. But you have to engage that patient. So you're applying it. That doesn't necessarily mean they're receiving it. So it's an assumption inside the step 4 that the application means that it's being received. That's where shared decision making can be very relevant to the application and implementation of a decision. If the patient doesn't trust you, they're not going to do it. I mean, I know that for a fact. I mean, I practiced as a pharmacist before I was a physician, and I had patients literally leave a physician's office with a prescription, come to the pharmacy, and say, is this the right drug for me to take? I'd rather just ask you. I hate to say it, but I just don't trust them. Right? That's happened before. And I have to be very careful in that position because I wasn't there for the decision that was made to prescribe it, but I have obviously some expertise and knowledge of understanding, well, what's your problem? What were you being treated for? What was your diagnosis? And then I can say, okay, well, that's a good drug, and yes, it seems appropriate, or, let me call the provider and just check in with them since you have a concern. So my job as a pharmacist, which we should have in place, is that checks and balances process so that our patients feel like they have some ownership and some decision-making power in this intervention, especially if it's something that's going to cost them a lot of money or has potential side effects. Because they're going to go home and do what? They're going to search it out on the web, and they're going to get all kinds of junk, right? That may be accurate and certainly inaccurate or bias itself, clearly. Right? So we want to make sure that they are engaged with the process, so application of the evidence isn't you just making a decision. It has to be received and accepted so that when you go to assess it, you're assessing real outcomes, not what you thought was done, but what was actually done. And how you're also assessing, how did you feel being on that treatment? Did it work well? Did you tolerate it? How was the affordability of it? Yeah, well, it was a little tight, but it was worth it. Or, I just can't do this. We're going to have to go to something else. I can't tolerate that side effect. Or that product is big and bulky, and I don't like carrying things around with me. Or I don't like giving myself a shot. Is there an oral option? All of those things are patient-specific factors and preferences that go into the success of the application of evidence, and then your ability to assess and then adapt your practice. Okay? So that's why I drive that point home. So now let's talk a little bit more about the assessment. Now, some clinicians will use step 5 as really step 0. I didn't talk about that before because we're diving a little bit deeper in each segment of this, which is why I want to make sure you watch the other steps of evidence-based medicine because it builds. But at this point in assessment, you might be assessing the patients for the question that's needed, right? So that helps you to ask the right question because you've made an assessment about the patient. Or maybe you applied something, it didn't work, and now you have to ask yourself the next question. Well, what am I going to do now? What alternative options do I have available to help this patient in this scenario? Okay. So how do assessments typically occur? Well, most time what we're thinking about is assessing our practice. That may be a chart review. It may be outcomes. There are sometimes groups that in that medical group, like the medical group I'm a part of, they They generate those metrics of how many patients do I see and what are some of the outcomes, how many bounce backs, whatever, those kind of things guide me. I still have to go back and review some of those individual cases. So I do a chart review, and sometimes I'll do callbacks. Call the patient back. Hey, this is Dr. Busti. I just wanted to check and see how that treatment was going, how you were doing. You know, and it's very interesting. It opens your eyes to a lot of what the patient is actually receiving and experiencing in this process of being a part of healthcare. And the other thing that was very eye-opening in doing that is that the patients were very appreciative. You know, we're all busy. We all have limited time. But when a healthcare provider calls you unexpectedly or without you asking, just because you care, wow. I mean, I was blown away by the response of the gratitude that most patients had in just saying, thank you for caring and checking on me. I appreciate that. Or a scenario maybe wasn't all right, like, well, let's get you back in. That's that customer service part where from one human to another, the human element needs to be something that we feed, right? So when we call and we assess them, we show demonstration of caring about them. In addition to caring about them, we do the right thing for them and make sure they get the outcomes. And quite honestly, what that does is it reduces the overall burden on the healthcare system. I've had a lot of patients, unfortunately, come in. I practice in the emergency department, and they come in and they're like, I tried to get in, but they just said, go straight to the emergency department. They'll take care of you. Well, like, I don't know all your information. I don't have all your records. It's not necessarily fair to me or the patient to do that. So there's obviously this balance, and I'm not saying that they can't stop everything they're doing in clinic to see every patient phone or answer every patient phone call that comes in. But there is some element of this management that we all need to embrace in taking care of our patients and being available for them, okay? The other thing that we're assessing here is in this particular bullet right here, which is we're assessing the effectiveness of steps 1, 2, 3, and 4. Did we find the right data? Did we interpret it correctly? Did we apply it appropriately? So we're assessing also the process of implementing evidence-based medicine and identifying tools and methods for how we're going to answer the next set of questions that we utilize. It becomes easier. As I've done it over time, I'm more efficient because I know where I need to access a certain type of information quickly. What level of data do I need? And I know where to get it quickly if I need to, right? So that assess and adapt, and that step 5 is really there to hopefully change our behavior and improve our overall practice if you're willing to allow it to do that, okay? So using the process of EBM and the 5 steps can aid us in systematically, okay, in a reproducible manner, allows us the time that it takes to make more educated, evidence-based medical decisions for our patients that will improve outcomes. Now, this requires us to integrate our clinical expertise, the patient preferences with that evidence. And it also, in step 5, reminds us to be proactive to determine that the impact of our efforts and the outcomes are actually being made in the decisions that we do. What does it look like? So I hope you found this series helpful in establishing the foundation of what EBM is, what it is not, how to do the process of evidence-based medicine as it relates to a singular patient care scenario, but then how that starts to evolve in your overall practice of multiple patients, and then how you fit into the larger system that makes up evidence-based health care. Because when we all do that, we're all participating in lifelong learning, we're all implementing the best available evidence as much as we can and caring for the patients and making sure they're empowered, and also participating, well then, man, wow, then we begin to truly move away from just practicing medicine to transforming it. So I hope you found this to be helpful. For those of you that are not subscribers or followers, please like this. Follow us at thisiswhy.health. We offer free subscription there so you get access to not only lectures like this and organized playlists, collections to make it easier. You can use these to help guide some, if you teach, and those, if you don't have the time to teach it, you want somebody else to teach it, these topics are hopefully there to help you. In addition to that, you can have access to some of the downloadable tables and tools that we've discussed in this series. Use them, share them. If you're studying for exams or your boards, these are great study tools. I wished I had had them. They evolved over time, but man, it continues to evolve. It's cool. And we'll be hosting other things, including newsletters to keep you up to date on other topics that may be of interest to you. So thank you for joining us, and I'll see you next time.